Okay, hello everybody. I'm pleased to announce this month's Translational Science Seminar, which is being given by Chen. So Ben did his bachelor's in chemistry in China, then a PhD in informatics at Bloomington, Indiana. And then he went to Stanford for postdoc with Atul Butte, who does just incredible informatics work, chemical informatics and drug discovery, computational drug discovery work. And that's what Ben has been doing an outstanding job with. He went with Atul from Stanford to UCSF, where he was an instructor and then an assistant professor. And then about a year ago, we were lucky enough to recruit him here to a joint appointment in Peds and Pharmacology, Toxicology. Ben's doing very well. He has the K01 in big data to knowledge and is very, very active in moving his projects along. And he'll be telling us about harnessing big omics data and AI to discover new therapeutics for liver cancer. So Ben?
Yeah. Thank you, Dr. Liu. Thanks everyone for coming. I talked a lot about this topic of using big data and AI to discover new therapeutics at MCU. So today, because the seminar is about the translational science, I decided to change the topic a little bit. I'm going to delve into one cancer, liver cancers. The reason I chose liver cancer is simply because this is one cancer I've been working for over 6 years. So I can see something. And also, we discovered a few drugs, very promising drugs. So I think I can see something. And recently, we got a paper accepted in Nature review on this topic. So I'm very excited to share and summarize the opportunities and the challenge of using the big data and AI to discover new therapeutics in liver cancer. Talk about the liver cancer, we often refer to hepatocellular carcinoma, HCC, which is one major form of liver cancer. HCC is a serious global health problems, and it's the second leading cause of cancer deaths worldwide. It causes over 600 deaths every year. If you look at the map, it mainly occurs in undeveloped or developing countries in Asia, Africa. Because it's mainly occurred in these underdeveloped countries, its research is really lagging behind. HCC is mainly caused by various infections, HPV, HCV, because recently we already got the drug which is able to cure HCV. So HPV becomes the leading risk factors in HCC. In addition, alcohol intake and metabolic syndromes are also risk factors in HCC, especially the metabolic syndromes like diabetes, obesity are become the emerging risk factors in HCC. In the USA, about 35,000 new cases every year. It's far less than the 200,000 cases. So it's categorized as an orphan disease or rare disease in HCC. But look at the national trend in the risk of new cancer cases. Liver cancer is the top in both men and women in terms of their the risk of the new cases. The 5-year survival rate of HCC is about 70%. Well, from the 2011 to 2015, majority of the cancer, the cancer death rate decreased, but not for liver cancer. Look at this. Liver cancer is one of the cancer where the death rates are increasing every year. So it increased about 1.6% in men and 2.7 in women every year. So it's quite it attracted lots of attention recent years, evidenced in 2019 NCI annual budget plan. If you go to their budget plan, you will see that liver cancer is one of the cancer they highlighted. So this is very exciting time to study liver cancer. HCC is difficult to treat due to the underlying hypothesized cirrhosis and other complications. The first line treatment is surgical resection. Only about 10 to 20% of patients are resectable because of the majority of the patient diagnosis pretty late or with other liver dysfunction like liver cirrhosis. The treatment of the unsectable HCC include liver transplantation, local regional therapy like TAXI, targeted therapy, and immunotherapies. So for the targeted therapy, sorafenib is the first drug approved in 2007 and has been the only approved drug for 10 years until in 2007 when regorafenib was approved. But when you look at the structure of the two compounds, you'll be shocked. It's almost identical. There's only one atom difference. So I would say this because the pharmaceutical company plays the tricks, wanna protect their IP and when their drug gets expired. And also it's not very effective and there are some severe side effects. The immunotherapy, like other solid tumor, their response rate is about 20%. So there is an urgent need to develop more effective treatment for HCC. Well, in the last few decades, the advance of the technology really lead to the dramatic decrease of the cost of the sequencing. And today, when it costs about 1,000 to get a whole genome sequence, this really result a lot of huge accumulation of the genomic data, which we also sometimes call big data. In HCC, the number of studies have molecularly characterized HCC. And one of the phenomenal studies is from the TCGA, the Cancer Genome Atlas Network, where the expert genome sequencing, copy number variation, and RNA-seq, micro-RNA-seq, methylation proteomic data were generated, and from which they derived some interesting targets, pathway, or new disease, new like subclass of disease. So we wondering whether this data has been translated into therapeutics. Are there any challenge to translate the data, the big data, into therapeutics? So in our recent review paper, we look at 11 genomic studies here, and we summarize the common molecular alterations, mutation, amplification, deletions. Look at the mutation data. You will see there are few genes are commonly mutated. TERT, TP53, beta-catenin, ALB. So we wonder whether these genomic features have been translated into therapeutics. So in another analysis, we pulled all of the clinical trials, HCC clinical trials, from phase 1 to phase 3. There are about 3 groups of drugs. One is the kinase inhibitors, like sorafenib, regorafenib. They are both FDA approved drugs. Immunotherapy, PD-L1 inhibitor, PD-1, and CTLA4, and other group of the drugs. Then we map to their therapeutic targets. Look at the expression of this target in the HCC patient samples from TCGA database. And you find that all of the targets only expressed in a very small set of the HCC patient samples. So which means the drug, the drug might be not working if we just directly apply to HCC patient without stratify the patient based on their biomarker. More strikingly, when we map the genomic feature and their therapeutic targets in trials, only 2 genomic features are being investigated in the trials. So there's a huge gap between the genomic features and the therapeutic targets in the clinical trials.
So Ben, in the genomic features, are you just looking at mutations, or are you looking at amplifications, overexpression?
Yeah, we look at here, we look at mutation, look at their amplification, deletion, yeah, there's several others. But majority of them are mutations. We also look at their expression here of the existing drugs, existing targets. There are multiple reasons first of all, majority of the mutated genes are undruggable, right? Like TERT, beta-catenin, LV, they just simply don't have favorable binding targets. We cannot find a small molecule directly targeting their gene products. Some genes like TP53, they are suppressors, right? There's no way to directly targeting these genes. For those genes which are druggable, some like the pike kinase inhibitors, they are simply cover a very small number of the patient samples. If we don't stratify the patient, this compound may even fail in the preclinical study. That's why I saw the huge, their huge gap. And this also suggests that the conventional targeted-based approach might be not working in HCC. Well, the target-based approach was first proposed even before the emergence of the Omics technology, right? And also, it does not take advantage of the high-dimension genomic features generated from the next generation sequencing. So we think we probably can use a different approach. We are proposing use a system approach. Instead of looking at one individual target, we look at a list of the disease genes. Because of the advance of the sequencing technology, we can easily profile the expression change after treatment of the compounds in the cancer cells. So we can easily know which genes were effective after treatment of this compound. Then we can map the signature, gene expression signature of these compounds to the disease signature, which derived from the comparison between the disease samples and the control samples. If the compound can increase the expression of the downregulated disease genes, then we think that compound may have some therapeutic effect. If that compound can suppress the expression of the upregulated disease genes, we also think that compound may have some therapeutic effect. Again, instead of looking at individual genes, we look at how the drug affect a list of disease genes.
So Ben, in this approach, it seems like you're assuming that all HCC is the same. You've got one signature for HCC. Is there any evidence? Certainly breast cancer, we know there's multiple subtypes, and they have very different gene expression patterns. If you look at HCC, do you cluster them into different subtypes, or is it really very homogeneous like this seems to imply?
Yeah, so in HCC, people usually classify the HCC based on the risk factors, like various status. HPV,
I'm just thinking about using the genomic data that you've got.
And there are another way, is just simply based on molecular data. They also have the 3 group of the samples. And in our case, we actually create a signature for each individual, each individual subtype.
And how many subtypes do you think you've got?
Well, for this case, we actually I don't have that slide to show, but we didn't see very clear like clusters. It's not like breast cancer. You can see there a triple negative breast cancer really far away.
So you'd
from
say it's
others.
really one large group
Yeah, one
from the
large
genomic
Yeah.
perspective.
Yeah.
I think the TCGA data says there's 4 groups.
Yeah. Oh, I don't know. Yes, 4 or 3. Yes. They no, then they group them based on the multiple molecular features, like the not only gene expression. They look at multiple type of the molecular features. So before the TCGA, there's one group. They group them the HCC into 3 clusters. Then I propose this idea to my collaborators who, as a physician at Stanford, he said, don't worry about the subgroup, because there's no treatment at all. So we just needed to try. Yeah, but in our case, we indeed stratify the patient based on their risk factors, and we found our drug can reverse the signature of each subtype. Well, we have lots of work on to move this to the personalized cancer therapy. I can show you that later. Well, we knew this work is not it's not trivial. You know, there are many computational challenge. For example, how to select the right tumor samples, how to create a robust disease signature, which cell line should we choose for the validations. So we develop a data-driven approach to guide therapeutic discovery. We start with open data, so all of data are publicly available. So we start with open data, build the model, use the model to guide the next step. Then we pull out the data from public database and build the model and move to the next step. I can show you some of the analysis for liver cancers. Yes, first we create a disease signature by comparing about 200 HCC tumors and 50 adjacent normal tissue samples. The signature consists of 274 disease genes, and some genes are upregulated, some genes are downregulated. But the disease genes can separate the tumor and non-tumors very well. To validate our disease signature, we further compiled about 1,000 patient samples from public database, and we found our disease signature can separate tumors from non-tumors very well in different data sets. So this just show you the signature is quite robust. They use the signature.
Go back to
And then does
the,
go ahead. Does that include patients then from these different proposed subgroups then? I mean, how many tumor samples are there?
So each dog is one tumor,
Right.
is one samples.
Yeah.
In total, it's about like 1,700 samples.
Yeah.
But here I only show the 3 data set. Actually, we're using about 6 data set.
so go back to the previous slide with the heat map. So there, looks like if you look at the purple ones on the right, there definitely are some differentiations. There's like a stripe of red all the way across, and below it a stripe of red alternating with green.
Yeah.
So that clearly looks like you've got some subgroups.
Yes. Indeed. There's yeah. Depends on I would say depends on disease signature, disease genes you are using to cluster. You may get a different clusters. Yeah. But indeed, if you want to use it, because it's a high dimension features, right? You change the feature, you will and get different type of the clusters. Yeah. So using the disease signature, we cram our drug library consisting of pretty much all the FDA-approved drug and the drug in the clinical trials. Here, the red shows the upregulated genes, the first column, disease genes. The green shows the downregulated genes. Remaining column are the drug signatures. So if you want a drug to reverse the disease signature, we want the red color on the top and green color on the bottom. And you can see majority of our compounds can reverse the disease signature substantially, except the last one, which we add on purpose. It's random drug. Surprisingly, we found a group of drug on anxiety drug, which is an anti-parasite drug, can reverse the signature. So we think this is very interesting. Right? We can say deworming pills can cure HCC. So we decided to validate the top candidates, niclosamide. Well, before we go into the bench lab, we always have to be very careful about our predictions. So we try to validate our drug hits computationally. We did a very simple experiment where we scored all of our drugs and ranked them based on their potency to reverse disease signatures. The green shows the compounds can reverse that disease signature. The green shows that compound can reverse the disease signature. Red shows that compound are unlikely to reverse that disease signature. Then we pull out all of the HCC drugs being investigated in the clinical trials. Well, even many of them may not be effective, but we think if our hypothesis is right, majority of the compounds should be able to reverse disease signature. And you can see, indeed, this compound can reverse the disease signatures. And if you look at the top one, sorafenib, this is the FDA-approved drug. And our drug, niclosamide, is much better than sorafenib. So we move forward to test this in a cell line. Again, there are a number of cell lines available, liver cancer cell line available, but which cell line should we choose? We cannot randomly choose any two cell line, because if it didn't work, your collaborators will never come back to you. So we are very careful. So we try to use big data to help. So we correlated the tumors and the cell lines using their gene expression profiles. Well, even there are a number of cell lines are not correlated with the tumor samples, but the two cell lines, HEP2, 57, are highly correlated. So we decided to validate our drugs in these two cell lines. And niclosamide, we found that niclosamide can reduce the viability of HCC cells. So this really get our collaborators excited because the IC50 value is even lower than sorafenib. Then we had the trouble. This compound has very poor solubility because this compound is designed to kill the parasite. It's not designed to be absorbed by our human cells. So we had the trouble, and we kind of was very desperate that time.
So then what happens if you try some other kind of normal hepatocytes or fibroblasts or some non-cancer cell?
We did, yeah. We try other.
What happens?
Well, we look at their cytotoxicity in normal hepatocyte and liver cancer, and we found that therapeutic windows are a few fold difference.
A few fold.
Yeah, that's
A few fold doesn't count for me. A few logs counts. two fold is nothing.
Oh, a few is 7. It's 7 to 8.
That's maybe.
Yeah.
Maybe. That's starting to be interesting.
Yeah, we talked to a bunch of advisors when this program, this project was selected in a Spark program at Stanford, and they said, well, 7 to 5 maybe again, maybe, but not optimal. But again, so there's no drug effective in HCC. That's why we are very excited about this.
Have you tried drug combinations?
We tried. I'll talk about later on. Yeah. Yeah. So that time we saw a paper published in Nature Medicine use the niclosamide salt, niclosamide astronomy, to treat diabetes. So we decided to try this the salt of niclosamide, NEN, and we found that NEN can reduce the viability of HCC cells. Then we move forward to the animal studies, and we found that NEN can inhibit tumor growth in 3 PDS models, patient-derived mouse models. And you better see the tumors here. We know the PDS model is great, but it's an immunocompromised model. So we decided to test our compounds in a primary mouse model where the immune systems return. So this is the primary mouse model induced by oncogene, MYC, and ROS. And we saw that the AEN can inhibit tumor growth in primary HCC models as well. Then because we saw there are still some residues there, then we decided to try combination. But which drug should we combine with our drug? So that's very tricky, right? We cannot run all of other drugs. Then we went to the clinicaltrial.gov. We pulled all of the current cancer combination trials. We try to understand the pattern, right? And we found that we often tend to combine the drug with existing therapies. There are many reasons. One reason is the regulatory, right? If you wanna show superiority of your combination, you have to prove each one your combination is better than each single agent. So that's why people tend to combine with existing therapies. So at that time, sorafenib was the only FDA-approved drug. So we decided to combine with sorafenib, and this is the control. This is our drug, and this is sorafenib. And you can say our compound is effective as sorafenib, but the combination has much more profound effect. Right? You barely see the tumors from the two mice based on the image data. So on the computational side, because we are using the drug profiles to measure the reversal correlation, but the drug profiles are from the cancer cell, right? So they're different from the patient. So we decide to pull out the tumors after a few weeks treatment of our drugs and profile them, and we found that the expression of the two 74 disease genes was significantly reversed, which means by reversing the expression of the disease signature, we are able to find the effective compounds for HCC.
Then, if you kept treating these mice with this therapy, would those tumors come back, even the ones that are small? You said after 2 weeks.
6 treatment, yeah. So we tried different we will try many experiments. So for this compound, later on we tried in many weeks treatment, and we saw the significant inhibition of tumor growth. But for this study, to be able to pull out their gene expression profile, because you cannot wait too small, right? If you wait too small, we couldn't get the tissue sample to profiles. So after like 6-week treatment, we sacrificed the mice and took the.
Yeah, so you can't tell from this study, but you could use the same treatment for longer to see if drug resistance develops and they relapse.
So could this reversal of the HCC gene expression pattern just be due to the fact that you've reduced the fraction of tumor cells versus stroma and other elements in your tumors?
Tumor, non-stem cells.
We also did the same experiment in hepatitis 2 cell lines.
In vitro.
Yeah, and in vitro, and also see their reversal correlation. Actually, that's much stronger correlation.
Have you thought about using like an RNA-seq approach so you could see that population shrink and then zero in on just a tumor cell population and then look at your correlation?
You mean single cell?
Oh, sorry, yeah, single cell, not RNA-seq.
So, that's probably the future plan. Yeah,
Okay.
yeah, and not for this. Yeah, that's the point. I gotta talk about the single cell data we've been working on this. Yeah, so this is a great story, isn't it? But to be able to publish in a high preferred journal, we really needed to understand why. Right? Not only this compound can reverse the signature, we need to understand which targets, which pathway were affected by this compound. So we did RNA-seq analysis of the cancer cell after treatment of the compound. We know this compound can target mitochondrial, and Western plot shows this compound can target multiple classic cancer pathways like BRAF, like Wnt pathway, mTOR, but all of them are indirect effect. It's not like direct effect. And later on, we found this compound can bind to CDC37 and disrupt the complex of the headshot protein 90 and CDC37. Well, when we know the compound is effective, is much understanding the biology is much more enjoyable, right? Because biology is always complicated. We always can make a good story on this. Later, we are still, yeah.
What is CDC37?
Sorry?
What is CDC37?
CDC37, yeah, I recall my memory. Yeah, I can't remember. It's been a while. But I know the heat shock protein lighted, and it's very popular and degrading many proteins. Well, later on we found this compound can physically interact with other targets. Basically, this compound is very dirty, and sometimes we call it polypharmacology. But in HCC, we think polypharmacology is beneficial. Yeah. Well, this is not good for medicinal chemists or the potential investors, right? They are interested in single targets because it's much easier to optimize this compound and move that forward. Right? For the multiple targets, it's just simply impossible. So this suggests us to look at some novel targets from our approach. Then we hypothesize that if the disease genes, which are reversed by our drug, might be their therapeutic targets. There is a list of disease genes suppressed by the NEN and nicotinamide. Then we choose HMR. The reason we choose HMR is simply because it's the only receptor here. So we think potentially we can develop a drug targeting HMR. Then we observe the HMR as overexpressed in the HCC tumors, and the lockdown of HMR can inhibit the cell invasions. But that's the only positive data we get. Other data are quite negative. We didn't see the protein expression. We tried many antibodies. None of them working. And we didn't see the compound can reduce this cell variabilities. Then we come back and say maybe it's reasonable because this such complicated disease, targeting one protein might not be working here. That's what I thought. Then we decided to come back to our compounds. Well, nicotinamide itself is not soluble, so we don't think we're able to move nicotinamide forwards. And there are actually a couple of clinical trials using nicotinamide to treat cancers, but all of them failed because of the potency. Then we also think about the NEN, but the probability analysis reveals that someone claimed this kind of invasion. There one sentence, just the nicotinamide or nicotinamide salt can treat solid tumor. So that one sentence basically kills this idea of moving NEN forwards. So we decided to try other approach. One approach to optimize this compound, then you try different formulation to increase the solubility. So this is one approach we are using. Basically, we're trying to break down the drug into very tiny particles, and then using the microemulsion to coat this and then deliver to the mice. And the new formulation of nicosamide can inhibit tumor growth, and it's almost as effective as the NDM, and didn't decrease the body weight. So this is quite promising. But later on, we just recently get a result. We found that if we wanna achieve the same efficacy, we need a large amount of this drug, and we get a large amount of this drug. Seems like this surfactant can do some toxicity, some severe side effect. So we're still trying to optimize this formulation. If any of you know someone can help with this, please let me know. We're still trying to optimize this formulation. Meanwhile, we also collaborate with medicinal chemists who help us develop a number of the analog of nicosamide, but none of them are as good as nicosamide. Well, there are some SAR we can use. My medicinal chemist suggests. Then we figure about, because my lab is computational lab, I don't want to spend lots of the efforts trying to optimize compounds based on empirical experiments. So we think whether we can use AI to help us design these compounds, and whether we can further understand some underlying mechanism of this system approach. Then we did some big data analysis. We pulled all of the compounds which have been tested in HCC cells, and we get their drug efficacy. Then we compute their potency to reverse the HCC gene expression, and you can see the potency to reverse this gene expression is highly correlated with drug efficacy, which means if the compounds here, if they show high potency to reverse the gene expression, more likely this compound is effective. So maybe you don't have, so based on this plot, you probably don't have to run biological experiment. You just use this score to be able to predict their drug efficacy. So we saw this pattern in other cancer as well. So this is really great finding. But it's not good enough to publish in Nature Communications. We need to run biological experiment. Then we use an approach. We scored about 12,000 compounds, and we asked our collaborators to select a few representative compounds, which show high potency to reverse disease signature, and also present different mechanisms. So they select the 4. And look at the chemical structures, they are quite different. Then they tested these compounds in 5 HCC cell, cancer cell lines. And the right shows the median IC50 value, and you can see they're very effective, all of the compounds.
Is it based on growth inhibition, or what? How did you get?
This is the in vitro, just look at the cell viability. And this one, the xenograft, we choose the trivalium. This one with like 70 nanomolar, which is very effective. And this is the inhibition, like tumor growth, like to look at the size of the tumors. And you can see this compound can significantly inhibit the tumor growth.
Did you ever try pamoate alone? Because pamoate is often used as a salt. It has been found to have biological activities on its own.
Pamoate?
Pamoate. It's pyridinium pamoate.
Uh-huh.
Pamoate's a pharmaceutical salt for...
I don't think we tried, because in our prediction, we have the pyridinium pamoate and pyridinium. Both compounds show high potency to reverse.
In your experiment, in your computational data. What if you just put pamoate in your cells? Does it do the same thing as pyridinium pamoate without the pyridinium?
That's a good question.
So Graham Milligan in Scotland was doing a high throughput screen, and they got hit with a pamoate salt. And when they sorted it out, it turned out there was a PAM-08, not the other component that did it. So I just get them to run PAM-08 in your dose response curve in vitro and see if it does anything.
Probably gonna affect the efficacy, but I think the primary.
Maybe the PAM-08 has all the activity. Maybe the Previnium isn't doing anything.
No, actually the Previnium, and we look at the mechanism, and there are a bunch of other publication look at a study Previnium, and this drug targeting Wnt pathway, and we test that and we found the Wnt pathway were effective.
Did they use Previnium PAM-08 also? That's the most common salt people use.
Well, I have to check that. That's a good point.
Easy experiment. Just throw some PAM-08 into your cell culture and see if it does anything.
That's
when it doesn't, come back and tell me, see, I told you.
Well, the paper we published, I don't have to do any additional experiment.
Yeah.
The problem with this drug is too toxic. Even it's like 70 nanomolar. But again, if we look at first of all, it's also mitochondrial coupler, the same as nicotinamide. And so we think there's no, it's not interesting to prioritize this compound, even we have lots of data here. Yeah.
And yet, remarkably, it's another anti-momentum. It's a drug used to treat pinworms.
Yeah.
You know, one of the mildest human diseases because it's luminally active. You don't need to absorb it.
Yeah. It has the same problem with the nicotinamide solubility issues.
Right.
So either drug will have to address the solubility.
Which was a good thing for it when you wanted to treat pinworms. It was good that it wasn't soluble. You didn't have to worry about the toxicity.
Well, but this just shows you the potency to reverse disease expression can predict drug efficacy in vitro and in vivo. So which means we can use this approach to do not just go screening, right? If we have the profile of the compounds. But to be able to do not just go screening, we need their drug-induced profiles, right? To get the drug-induced profiles, we have to do the sequencing, have to do experiment. But that's very expensive. It's just impossible to get the profiles of millions of compounds. Just impossible under different biological conditions. So we decide whether we can use the existing data and the advanced model to be able to infer their gene expression profiles. So this is a signature. Ideally, right, if we can find the compounds which can totally reverse disease signature, that compound might be ideal. And we know that gene expression change depends on many factors. It depends on the chemical compounds, right? Also depends on cellular context, and also depends on their treatment conditions, like dosage, times. But how can we incorporate this information into our models? That's a very, very challenging problem because the chemical compounds, how to model chemical compounds, how to model cellular context, how can we incorporate this dosage term into the model? Right? And the traditional machine learning model is not very helpful. That's why we decided to use deep neural network, which may be able to handle the heterogeneous features. And that's one of the reasons we hired Dr. Jin Xin here to work on this problem. Well, this because it's very complicated, we decided to focus on one genes. We are looking at MYC. If we are able to predict the expression change of MYC after treatment of any compounds, then we can expand to other genes. Right now, we just give a first shot and try the MYC expression. So this is our first try. We are using the about 57 gene drug-induced profiles. We split the data set into training set, easy test, and hard test. So hard test, in the hard test, the compounds are quite different from the training set. Well, we are first to try using the standard approach, like ECFP is kind of very standard molecular fingerprints used in pharmaceutical company. So we use that to represent the compound. We also trying to use the advanced model, like this is the graph convolution network, which is recently developed. We work with Professor Jackie Zhou's lab at MSU, the computer science department, to develop this. This is some result, and this very complicated, many complicated terminology, but I will not tell. I want to show you here. This is the correlation. This is the correlation between the predicted value and the original value. So we want the correlation as high as possible, right? 0.2, which means it's marginal. They are kind of correlated, but a lot remarkable. Well, we cannot expect the perfect correlation because the training set itself is quite noisy, right? You know, the high throughput screening, the profiling, we couldn't get any perfect training set. But as long as the correlation reached to like 0.7 or 0.4, I would be very confident to use this to do large scale screening.
I'm sorry, what were the data you were using for this, the experimental data?
So experiment data, so here we're using the existing drug-induced profiles. That's from links about.
Okay, so it's links database and it's looking at all cell types?
Not all cell type. Now they cover 75 cell type.
But it's all the cell types that are in links?
Yes.
Okay.
Yeah.
So basically using links database to predict the expression levels, you leave out 20% of the compounds and then see if you can predict the links data back for those 20%.
Yeah.
Got it.
Yeah, you're a machine learning expert. Yeah. Well, that's the general rules of basic machine learning approach. But because it's quite a challenge, it's really many factors involved. So we try to start a very simple experiment. We actually only look at the one cell line, MCF7. So we only look at the expression change in this one single cell line, and that's the predictions. But again, it's very complicated, right? Drug-induced profiles. There are many factors involved. So it's quite a challenge to be able to predict their expression change. But you know, the result is quite promising, but still there are huge space to improve. We are still working on that. But if we can make a good prediction, I would say we really can revolutionize the drug discovery process, right? We can start with the gene expression signature, find the compound reverse signature, then we can virtually screen millions of compounds, right? Even the model is not perfect, but at the end of the day, we still will go to the bench lab to test, right? But this model can really help us to prioritize some promising compound to start with. That's very cool. Yeah.
So Ben, what do you think you need to make the prediction better? Do you need just a lot more data? Just a lot more data in links? Do you need different data?
I need more people to work on this. Yeah, data is key. If as long as we're using the deep learning method, the data is the key. Yeah, but we still need more machine learning experts to help us to refine the model. The data already good enough. It's the links claim there are like 1 million profiles. It's quite a big data set.
So you are using the chemical similarity metric as part of your learning method?
You can consider, yeah, that's chemical similarity. That's probably the standard. We can consider as a baseline. Yeah, we'll try chemical similarity. You can look at like maybe use DRS labor to infer their gene expression. But that's kind of very classic machine learning method. We're using much more sophisticated method right now in the machine learning field.
Now, I guess I'm just trying to understand what the inputs are for the compounds,
Input is the fingerprints.
so that they're the chemical similar to fingerprints?
Yes, that's about like 1024 bits, right? That's the ECFP4. And you can consider the features. Yeah.
Okay.
Well, back to the biomarker, and earlier I mentioned about we have to develop biomarker for the drug because there's no targets can cover a significant number of the patient. But recently, people started to look at the microenvironment, and we think well, this is really cool because of single cell technology, we're able to look at the individual single cell. So this is a paper published last year in Nature Communication. They profiles the single cell of the normal liver organs. So each dot is one single cell. You can see very complicated. Even the liver include over 20 different cell types. Even the hepatocyte has like 6 distinct clusters. So hepatocyte has like 3 subgroups of cells. So that's very amazing. So we think, well, whether we can use this information to do something, right? So to start with, we use the signature of each cell type to quantify to estimate the abundance of the cell type in a bulk tissue from TCGA. And then we correlated their abundance with the survival. And we found some interesting stuff. First, the HCC patient with enriched endocellular cells in tumors have better prognosis. So here the blue line shows this HCC patient with enriched endocellular cells. And they have much better survival. So this is really, this is surprising to me. Well, first of all, it's not super surprising because we know the HCC cancer drugs, sorafenib is angiogenesis inhibitors. They're targeting blood vessels. So endocellular cells are associated with their prognosis is reasonable. But when I look at their direction, it's quite interesting because sometimes we saw if the tumors with more endocellular cell or blood cell are more severe, right? But here we observe if the patient need a lot of the endocellular cell to be able to respond to sorafenib. I was very surprised about this finding. Then we actually validated this finding using an independent data set, still same pattern, and we try to understand why. But this is really cool analysis, and it can show you that we can using the emerging data set like single cell to help us to understand the mechanism of the drug, or even to identify new biomarkers. Well, so this is the our pipeline for liver cancer. Some are all of them are ongoing, but then the goal is really trying to push one compound eventually into the clinical trial. If we're able to succeed in liver cancer, we can simply apply our approach to any other cancers. So my lab, I run out of time. So by now we are actively implementing this approach in different cancers. We are applied to like DIPG, is pediatric cancer, to study melanoma resistance. That's the work we are collaborating with Dr. Newbig's lab to try to find a compound to reverse the resistance in melanoma. We also can find a compound to targeting cancer metastasis or even the microenvironment. In molecular profiles, we're using gene expression data. Of course, we can use protein expression. We can use metabolite abundance, etc. And the drug signatures, well, people don't believe sunlight and they start using organoid or other advanced animal model. But as long as data are available, we can easily incorporate that data into our pipelines. So this just show you the cancer map we built up in the lab. Right now we already have over 20,000 RNA-seq samples, cover 40 cancer types. So literally we can predict the drug for every cancers. And this is the pipeline we built to help others to use our pipelines to make the predictions. At the bottom, all the data set we've been working on. So I have one assistant dedicated to compiling the RNA-seq samples. It's growing very quickly right now, the data set. And we also, on the top of the data set, we have the core, we call octet core. It can include many types of the bioinformatics modules, like doing enrichment analysis, DE analysis, normalization, etc. So on the top, we also have the desktop version, which allows computational biologists to use our model to run predictions. We also developed the web portal here. It's very easy to use, and I hope to be able to release the portal very soon. We are wrapping up the manuscript on this right now. So this is the last slide. We know this in the translational research, it's not about one single data, one modality, one data set, one model. It's usually a combination of multiple data sets, multiple models. From the patient, tissue sample, cell line, animal model, they are different biologically, right? Now we already have the data to be able to quantify their difference, to be able to know their similarities that help us to select the right cell line, right animal model in the translational research. So we might not be very interested in any idea of using the big data to help this process, the translational research. Again, so I really appreciate many people in the lab, and we are actively hiring more postdoc grad students. And this lab primarily a friend collaboration from the Stanford folks, Dr. Samuel So's lab, the liver Asian Center at Stanford. So they run all of the biological experiments. The work started with my postdoc training with AutoBuild when we are at Stanford. So I have many people I will appreciate, especially the Dr. English, Ubig, Asman to help me set up it. Thanks for your attention. 3 minutes over.
Ben?
Yeah.
Quick question and then a comment. The question, early on you said the mouse model that you had used to generate a lot of this data were liver cancers derived by oncogenes, right?
Yeah.
Did you compare or look at any model where the cancers, the liver cancers, were derived from a virus, not an oncogene, like hepatitis virus? The reason,
No.
okay, the reason I asked that question, and it goes back to Werner Lowenstein in '66. He noticed that all cancers from every organ lacked cell-cell communication.
Yeah.
What he didn't know at that time was a cancer cell that couldn't communicate with normal cells could do so either by not turning on the genes for gap junctions, or that the genes for the gap junctions were turned on, but the proteins were rendered non-functional by oncogenes. In other words, all cancers can be either derived from a stem cell, which doesn't turn on the gap junction genes, or they turn on the gap junction genes, but an oncogene has been activated that renders them non-functional. That means those two types of cancers cannot be treated by the same compound. Because, for example, a stem cell has ABCG,
Yeah,
drug transporter gene. So you throw any toxic chemical on it, it will pump it out. Stem cells are very resistant, okay?
yeah,
Whereas once you turn off the stem cell gene like OCT4, then those cells are rendered possibly sensitive to drugs like protein kinase inhibitors, because it'll knock out an oncogene that turns on a protein kinase.
yeah,
So this is very important. And the best example is human colon cancer. You have the polyp type
yeah,
and you have the flat type.
yeah,
The flat type is very embryonic, non-treatable. The polyp type is treatable.
mm,
And so this happens to be the case for every organ.
mm,
You know, basal cell carcinoma versus the squamous cell carcinoma.
mm,
The breast cancer, estrogen receptor, triple negative, not. You go through all of the organs and you find this dichotomy
mm,
of stem cell-like tumors versus partially differentiated tumors.
mm.
So this would mean, you know, first identifying in the patient whether it's one type or the other, and that way you can now start targeting your therapy to either stem cells or differentiated cells.
So looking at those heat maps,
Yeah.
you would think those would fall out as pretty separate groups.
Well, the trouble with that is every tumor in vivo and cell lines derived in vitro are mixtures. They're
Yeah.
always mixtures.
Yeah, I think the single cell technology will be helpful to identify the stem cell and to characterize the stem cell in the.
Yeah, those sort of show up, Jim, in those single
Yeah.
cell RNA
Because-
seq maps.
Because the
That's
tumor right now
right,
is just
and there's
mixture.
two very interesting markers. You don't need 26,000
Ah.
markers. OCT4A is the stem cell marker, and connexin is the gap junction marker. They can't be existing in the same cell. In other words,
One
OCT4
or the
makes
other.
the cell stem, and the connexin makes the cell differentiated.
Yeah,
You could look at that.
yeah, we can
Links.
look at the two biomarker, look at enrichment and yeah.
That's
You could look at that
exactly
in
what
links.
should be done. It's not being done.
I'm not an expert in stem cell. I don't know anybody use stem cell
You got-
for liver cancer. Yeah.
You got a guy right here.
Yeah, I should read more paper from you guys. But I don't know there one paper in Nature Medicine using single cell to study stem cell. Look at the cancer metastasis, and that's just a very recent work.
So you don't have a liver cancer stem cell model for your study?
No, we don't have. Yeah,
So that could be an organoid model, right? You can,
yeah, we can.
Use it to
Yeah, I know a few of my colleagues at UCSF. They are trying to build the organoid for liver cancers.
other question? Thank you.
Okay.
I think we have some refreshments out here.
Okay.